Okay, so hello everyone. This is Daniel Shahid. I'm a fourth year medical student, and this is our second episode of Neurology series. So, welcome to our Neurology series. Okay, so again, in this series, we're gonna discuss some core questions from the authentic USMLE sources, and we're gonna discuss their explanation, their correct answer, incorrects, and that's it. So, let's begin. Okay. So again, this is the first question, and you can pause the video and you can make the answer, make the diagnosis, right? So in an experimental setting, laboratory animals are exposed to a toxin that selectively inhibits the function of kinesin. Okay, on histological examination, which of the following structure is most likely absent from the tissue? Okay, all right. So let's break this one down. The way USMLE warrior should. The key phrase in the stem is a toxin that selectively inhibits kinesin. So that's your anchor in the stem. Now, what is kinesin? Kinesin is a microtubule. Let me show you. This is kinesin. So, kinesin is a microtubule associated motor protein that moves cargo anterogrately from the cell body towards the periphery like axon terminals. So think of it like a delivery truck driving along the cytoskeletal highway, transporting stuff like vesicles and organelles and proteins outward from the neuron's cell body towards the axon terminals. So again, this is the way the way the kinesin work. uh, from the red we have shown that kinesin are responsible in moving the vesicles anterogrately. So whenever you are talking about anterograde function, just think about kinesin and nothing else. Awesome. So now let's move towards our option and ask what needs kinesin to get where it needs to go. So option A, Nissel substance. Nissel substance is equal to rough endoplasmic reticulum of neuron, and it's located in the cell body, not transported anywhere. So this isn't the cargo item. It's more like refractory to the ship. It's more like factory, not the shipment, right? So Nissel substance is the factory, not the shipment. It's something that is producing, not transferring something from one side to another side. So it's not, again, it's not the function of kinesin. As I've told you, that kinesin is responsible for moving one thing from another side, when for moving anything from one side to another side. So the option B, secretory vesicles in the nerve terminals. Yes, these vesicles are made in soma. This is the correct answer. So vesicles, we know very well that vesicles are made in the soma, the cell body, and need to be delivered to the axon terminal to be released into the synapses. Kinesin is essential for this forward anterograde transport. If kinesin is blocked, vesicle pile up in the cell body and never reach the terminal. So again, B is the correct answer. Okay. Option C. Of course, the by the word T tubule, you are thinking of some muscles. So T tubule, option C, not dependent on kinesin. It's not dependent on kinesin. These are just invagination of the plasma membrane, a part of muscle cell architecture, not the transported structure. So it's incorrect. Option D, desmosome in epithelial lining cells. So these are cell to cell junctions formed in place, structurally integrated into the membrane. No need for transport, kinesin based transport. Awesome. Option E, microvilli. Okay, again, these are surface specialization formed locally by actin, not something needing kinesin to get there. So again, it's the wrong one. So the teaching point here is simple but high yield. That kinesin is responsible for anterograde transport, and the anterograde transport in the neuron is the a movement of vesicle to the axon terminal, right? So if you knock out kinesin, the axon terminal runs dry, right? If you knock out kinesin, the axon terminals runs dry of neurotransmitter vesicles. then that's your clue. Yeah, that's your clue for this question. So final answer is B, secretory vesicles and then nephrometals. That's it. Nothing more, nothing less than that. And again, you can see how the kinesin is shown here. I hope you can appreciate this thing. Okay, you can pause this question again, and then we will move towards our correct answer. But please don't think that I'm refraining from my previous strategy. I'm stick to that strategy, but again, I'm making this thing easier for you so that you can assess the question in your way, right? But again, how I reassess the question till now, I just read the last line, skim the options, and then move to the stem. This is how I assess the question of USMLEs. Okay, so a 44-year-old man with a history of HIV infection presents with progressive difficulty walking, and frequent falls for several weeks. He reports sharp stabbing pain in his extremities but denies headache or visual changes. He is non adherent to antiretroviral therapy. Neurologic examination reveals full strength in all extremities, absent deep tendon reflex at the knees and ankle bilaterally, and decreased proprioception in the lower limb. His gait is wide base. He has positive Romberg sign. Which of the following is most likely associated with this patient's current condition? Okay, so this patient has progressive difficulty walking and frequent falls for several weeks, and he is reporting some sharp pain, stabbing pain. Also, he has wide gait and positive Romberg sign. Whenever encounter positive Romberg sign, just think of that your posterior dorsal column is lost. It's it's gone. So all right. This question is a classic board style setup, and a patient with HIV having neuro symptoms and a stump packed with localizing sign. So let's break down the localizing sign here piece by piece. So, first, what are the main components in this question? Difficulty work. Awesome. Again, it's awesome for me to understand, not for the patient. Difficulty walking. Okay. Frequent falls. Okay, not good, not good. Sharp stabbing pain in the limbs. Oh, too bad. Next, what are the neurological symptoms? What are the neurological symptoms? Motor strength, it's normal. Reflexes, absent in knees and ankles, not good. Vibration and proprioception, decrease in the lower limb. Okay, and positive Romberg sign, wide base gait. Okay, now ask yourself, what's the theme here? What's the theme? This is the triad. This is the triad of loss of proprioception, ataxia, sharp stabbing pain. Oh my god, what else you want to need to know? This is the neurological signature of Tapes dorsalis, right? This is the neurological symptoms of signature of Tapes dorsalis, and it's a degeneration of dorsal column and dorsal column pathway and dorsal roots. So that's why the patient is also having sharp pain, right? So yeah, that's it. You can see that in this figure that I have shown. Of course, this picture is assessed from some public website. No copyright issue. But again, in this picture, it is shown that the dorsal column is lost. Right, it is not demarcated well. It is poorly stained. So on the histology, when anything, when any neurological structure is poorly stained, so we suppose that it is gone, right? So this condition is the Tapes dorsalis. It's caused by tertiary syphilis, and in HIV positive patients, syphilis can accelerate or become very severe and appear in the form of Tapes dorsalis. So now we can go to the options and can match with the disease again. Okay, so CSF culture growing acid fast bacilli. Do you think that it's a correct option? Of course not, because that's TB, and you would expect chronic meningitis sign like headache, fever, cranial nerve palsies, and that doesn't match this stem. Okay, and of course that doesn't match the dorsal column pattern. CSF PCR for a positive for herpes virus. I think this is the correct option. Is it? No. Usually, it is linked with HSV encephalitis, which affects the temporal lobe, right? So it would alter mental status and seizures, not this. Okay, so again, it's incorrect. Option C, encapsulated yeast on CSF India ink preparation. That's Cryptococcus, my friend. Classically causing meningitis in AIDS patient, you would expect headache, fever, photophobia, not purely dorsal column signs. Okay, option D, polyomavirus infected glial cells on brain biopsy. So that's GC virus causing PML, progressive multifocal leukoencephalopathy, which affects which causes demyelination of white matter, and you would expect focal neurologic deficits, motor weakness, vision problems, cognitive charges changes, not dorsal column. So again, that's incorrect. Of course, the option E is the right one because CSF PDRL detects neurosyphilis, and in this case, Stapes dorsalis, classic tertiary syphilis with posterior column and root degeneration. Perfect, fits everything, everything. So, option D, ring enhancing lesion on brain MRI. Oh, that's toxoplasmosis gondii, and which causes focal deficit like hemiparesis, seizures. But again, not this, not this. Purely sensory, more posterior column pattern. This is for then again. I've explained you that the posterior column pattern is in the neurosyphilis, tertiary syphilis. Okay, that's what we were talking about, man. Okay, so the pearl to remember: if you see ataxia, if you see lightning pains, and decreased vibration and proprioception, positive Bromberg, think of tape dorsalis, tertiary syphilis, test CSF PDRL. Nothing more, nothing less than that. That's the correct answer. Okay, let me tell you one thing, one extra thing. Of course, that's not a part of your step one exam, but you should know it. That for the syphilis, we got different tests like FTABS and VDRL. So VDRL is a non-treponemal test. It's sometimes it's not positive, right? So it's not a it's a go-to test for your step one exam, but in the clinical settings we prefer FTABS because it's a treponemal test. And one more thing, it has high true positive ratio, the FTABS test, right? So in the clinical settings, most of the healthcare people go for FTABS rather than VDRL because again VDRL is sometimes false negative. Okay, sometimes it is also false positive in antiphospholipid antibody syndrome, right? So that's a totally different thing again. You would expect some hypercoagulable condition in the patient in that condition, but I would just giving you an extra knowledge. If you don't want to listen, if you don't want to remember, just you can throw that information. That's for that's more for a step to CK, not for a step one exam. Awesome. So okay, the next question. You can pause the video and you can make the diagnosis, mark the correct answer. Okay, a 65-year-old woman presents with worsening urinary urgency and incontinence. She denies dysuria, abdominal pain, or changes in urinary frequency. Means there is no probably there is no urinary tract infection. If there is no dysuria, so don't think of UTI. 80%, 80%. She reports involuntary urination episodes due to an inability to reach the bathroom in time. She feels unsteady while walking and has a slow shuffling gait. According to her family, she has become forgetful and struggles with planning tasks. Okay. Past medical history includes hypertension. Vital signs and physical examination are unremarkable. Neurologic evaluations reveals impaired attention and short-term memory. MRI of the brain shows chronic white matter changes and diffuse ventriculomegaly without sulcal enlargement and infarct or mass effect. This is a huge giveaway of your question. Honestly, what else you are expecting to from the examiner to tell you? Which of the following best example the pathophysiology underlying this patient's urinary incontinence? Okay, so I have highlighted the buzzwords here. Now, this is a beautiful, literally, I would say it's beautiful. This is beautiful high yield step one question. We are dealing, and in this question, we are dealing with a triad. And once you spot it, the diagnosis locks in a key, like a key in a door. Honestly. So let's pull out the core clues from this from this patient's story. Urinary urgency and incontinence. Number one. Number one. Urinary urgency and incontinence. That's I have highlighted here. Okay. Gait instability, shuffling, and a slow walk. Number two. Okay. Number three, cognitive decline, forgetfulness, and executive dysfunction. That's a huge giveaway. This is a classic triad of normal pressure hydrocephalus, and we remember this as wet, wobbly, and wacky. From wet, we means, of course, yeah, urgency incontinence or incontinence, right? From wobbly, we means the gait is wobbly, the gait is ataxic, and from wacky, we means dementia. Now, the MRI, I can show you the MRI. Yeah, this is the MRI of this patient. Now, the MRI confirms that ventriculomegaly is without sulcal atrophy. Remember, when the ventriculomegaly is without sulcal atrophy, it means that the ventriculomegaly has nothing to do with your cerebral cortex or with your cortex. Remember, let me tell you one thing, one important thing. When does ventriculomegaly occurs? There might be two possible causes. First, it is possible that ventriculomegaly is due to the primary defect in the ventricles, that ventricles are over enlarged, of course, due to obstruction in CSF flow. Or secondly, the ventriculomegaly can happen due to sulcal atrophy, because if the sulci, if the cortex is undergoing atrophy, then it is giving a more room to the ventricle to enlarge, right? So that's is the another cause of ventriculomegaly. But in this case, the MRI doesn't show ventriculomegaly, so that's it means that you don't need to think about any cortical pathology. Let me show you. This is the case in which you can see the sulcal enlargement. You can see that sulci are deep and indented and are visible. So in that case, you would think, okay, that's a sulcal atrophy is going on, and due to sulcal atrophy, the ventricles are enlarged, and that's why you are seeing ventriculomegaly on the MRI. So that's a different case. That's more happen in Alzheimer's. So this MRI is from the patient of Alzheimer disease, right? Again, so I think that I've made myself clear here. So yeah, let's move to our question. Okay. So yeah, what I was talking about, I was talking about some ventriculomegaly. Okay. So yeah, here you go. Okay, so again, there is no mass or infarct or no hemorrhage. The MRI confirms that. So, what's actually happening? I mean, what's the pathophysiology? The large ventricles stretch the cortical fibers, the descending cortical fibers precisely, and especially those from the frontal lobe that regulates your bladder control, gait, and cognition. Right? You know, frontal lobe is precisely for the urinary control and for your behavior, for your cognition, for your intelligence, and for your gait as well, right? Not your gate, I mean the gate, Gait gate, not your GATE gate. So yeah, so now let's move towards our option A, cerebral dysfunction. Cerebellum helps coordinate movement and balance. Yes, damage causes gait problems, but not dementia or incontinence. So that's not the full triad. So option A is incorrect. Compression of reticular formation. Oh my god, do you know what is the function of reticular formation? Reticular formation is responsible for the consciousness. When the patient is in coma, it means that reticular formation is gone. Okay, so again, reticular formation affect the consciousness and arousal. not the frontal lobe. So again, you won't see the frontal lobe driving symptoms here. So again, that's it. The option B is is incorrect. Option C, impaired basal ganglia signaling. Again, that's classic for your Parkinson's. Shuffling, you have to think of shuffling gait, and yes, there would be some urinary incontinence, but it's not early. In Parkinson's disease, urinary incontinence is a very late finding when the disease is severe. So again, you don't need to think about Parkinson's disease. Again, in the Parkinson's disease, patient have some other symptoms like masked faces and some tremors, right? So again, that's not the case here. And keep in mind that step one always assesses classical scenarios. Step one don't mix you with some uncommon things. It always give you classical scenarios. Always, almost always. Okay, option D, spinal cord damage. That would affect motor and sensory signals as well, probably causing incontinence, but wouldn't explain cognitive decline or gait dysfunction unless it is very severe. So MRI would also show cord changes, not ventricular dilation here, of course. So incorrect. Option D is incorrect. Of course, option C is the correct one. So yes, these fibers from the frontal cortex descend near the ventricles and help control maturation, bladder control, and executive functioning, planning, and gait initiation and coordination. So when the ventricles expand, these tracts get stretched, and the classic NPS appears. Triad appears. So key insight there here is that these fibers are functionally disrupted by mechanical stretching, even though CSF pressure is normal on lumbar puncture. You know that the reason why we say normal pressure hydrocephalus, a normal pressure hydrocephalus, because if you tap these patient via lumbar puncture, the lumbar pressure will be normal, but still they are having hydrocephalus. Awesome, awesome. But in such patients, lumbar puncture may improve the symptoms. Let me tell you one more thing, a very important thing. I would say that remember this thing, keep this thing in the back of your mind for the rest of your life. No one gonna tell you, literally. NPH, normal pressure hydrocephalus, the demographic or NPH is very important. Very important. It is in patients who are uh, elderly women, classically from I guess adolescent female and some adult female, right? Adult female and adolescent female, it is common in them. One more thing in the demographic is that obese women are more likely prone to this condition. Honestly, I've seen these cases. Obese women are more likely prone to NPH, normal pressure hydrocephalus. One more thing I want to tell you guys that the treatment of normal pressure hydrocephalus depends on the severity. Sometimes normal pressure hydrocephalus affects the eye as well, affects the vision as well. So in that cases, we go for lumbar puncture. But if it's not affecting the eye, if you are not seeing papilledema on the frontoscopy, if the vision is intact, so you can go for acetazolamide, just lowering down the production of CSF. Awesome. But again, if you don't want to remember these things, you can just skip. These are more of some clinical exposure, not your thing right now. Awesome. Okay. Now, question number four, I guess. So, you can pause the video. Okay. A 57-year-old man presents for follow-up of Parkinson's disease. His motor symptom remains well controlled with anti-Parkinsonian medication. However, his wife expresses concern about a recent behavioral change. He has started gambling excessively and has lost a significant portion of their saving. Man, he frequently drives out of the state to visit casinos. Okay, yeah, I hope you guys understand that we are talking about here pathologic gambling. His only other medical condition is MDD, major depressive disorder, treated with sertraline. sertraline. Okay, I'm bad at pronouncing this medication, honestly. He does not use alcohol, tobacco, or illicit drugs. Vital signs are normal. On examination, he has mild resting tremor and minimal rigidity. Some which of the following is the most likely cause of this patient's recent behavioral change? Okay, so uh, yeah. So this is yeah. So this is a high yield behavioral neurology question embedded in the context of Parkinson disease, and it's classic for step 1. Not only for step 1, it's classic for step 2 CK as well. But I know that step 2 CK audience is not gonna see my videos because they are for solely for step 1. Okay, so let's start by identifying the main clinical issue here. The key finding is new onset compulsive gambling. I hope you understand what do I mean by compulsive gambling. That the patient is getting satisfaction with gambling, right? So, compulsive gambling in a Parkinson's patient whose motor symptoms are stable. So what's going on? So Parkinson disease and dopaminergic agonist. Now let's talk about this thing. It's very interesting. So Parkinson disease is characterized by dopamine depletion, right? We both know. You and I know very well that it's caused by dopamine depletion in the substantia nigra, pars compacta. So that affects motor control via nigrostriatal pathway, right? Pars compacta control the motor control the motor cognition, right? Via the motor control via the nigrostriatal pathway. But treatment isn't just about the motor control. It also affect when you are giving treatment with dopamine agonist. So those dopamine agonists not only gonna act on your the nigrostriatal pathway, that gonna act on mesolimbic pathway and mesocortical as well. And these pathways are involved in reward seeking behavior, impulsive control, mood regulation, right? So this patient has started gambling excessively. That's a textbook example of impulsive control disorder, ICD, and is a known side effect of dopaminergic pathway. Sorry, and it's a more major side effect of dopaminergic therapy, especially dopamine agonists like I guess pramipixole or ropinirole, right? They both are dopamine agonists. So even levodopa can cause it, but agonists are higher risk. So now let's go through the options. Decreased peripheral conversion of levodopa, option A. Okay, so this refers. Okay, so this refers to the use of carbidopa, which reduces the peripheral metabolism of levodopa. So it improves CNS delivery and reduces the side effect like nausea. So it does not, of course, behavioral changes or gambling, right? Okay. Option B, increase norepinephrine levels in a synaptic cleft. This would be more relevant in antidepressants like SNRIs, not related with dopaminergic therapy or gambling behavior. So that's incorrect too. Okay, option C, increase serotonin levels in a synaptic cleft. He is on sertraline, which is an SSRI that is used for depression. SSRIs don't cause impulsive gambling, right? In fact, they can improve impulse control in OCD type behavior. So again, that's not the correct answer. In fact, if there is something to do with SSRI, so it's serotonin syndrome, and that classically represents with hypertension and some rigidity and that some bizarre stuff. Okay, so stimulation of central dopamine receptor. Bingo, that's the core mechanism of this condition. So drugs used to treat Parkinson's disease stimulate dopamine receptor in the CNS, particularly D3 receptor in the mesolimbic pathway, which regulates reward and reinforcement. So this overstimulation can lead to pathologic gambling, hypersexuality. It's common, literally it's very common. Compulsive shopping or eating. So this is called dopamine dysregulation syndrome, or more broadly, impulse control disorder associated with dopaminergic therapy. So that's the correct option. Option E, upregulation of brain nicotinic acetylcholine receptor. So this is more related to nicotine dependence and does not explain the symptoms here, not relevant to the Parkinson's or dopaminergic drugs. So the final clinical pearl here is always watch for behavioral side effects for of dopaminergic therapy. ICDs means impulsive control disorders like gambling, hypersexuality, or compulsive spending may appear even if motor symptoms are stable. So management is taper or discontinue dopamine agonists. Literally, nothing more, nothing less than that. It's very easy question, and I think that moves towards our next question. Okay, a 21-year-old, I guess you can pause the video, right? Okay. A 21-year-old man is brought to the emergency department after his mother found him convulsing on the kitchen floor. During the episode, he lost bladder control and bit his tongue. He has history of post-traumatic epilepsy and has been non-adherent to anti-seizures medication. In the emergency department, he experiences multiple generalized tonic-clonic seizures in succession without regaining consciousness between the episodes. Intravenous lorazepam is administered and the seizures stop. To prevent recurrence, a second intravenous drug is started. Which of the following is best describe the mechanism of action of the second drug administered? So let me tell you one thing. This patient is having some tonic-clonic seizures, right? There are two important things I want to tell you. First of all, you should know what is status epilepticus. Status epilepticus is in the land of epilepsy or in the world of epilepsy. Status epilepticus is a thing or it's a condition in which your seizures extend from 5 minutes, in which the seizures are prolonged, and that's very, very, very dangerous, right? Because it can lead to neurological deficits and it would lead to some injury to your brain, right? When in which patient status epilepticus happens? Those who are non-compliant to their anti-epileptic medications, those who are having some withdrawal effect, like withdrawal from alcohol or any conditions like that, and those who are who have sustained some brain injury. So these patients are prone to status epilepticus. This is one important thing that I've told you. Another important thing I want to tell you that the status epilepticus is how we manage the status epilepticus. We manage first we try to sedate the patient. We try to stable the patient. Of course, when you are in the emergency department, the patient is having seizures continuously. You will first of all in the emergency department, you will first of all go for airway. You will check if the airways is normal, if the patient is breathing normally or not. Because patients who are undergoing seizures, they have lost the control of their tongue, and their tongue can prolapse backward, and that would lead to the airway obstruction, and that would prone the patient to hypoxia and can ultimately lead to death, right? So first of all, you will intubate this patient. Okay, you have managed the patient by intubation. What's next? You will give lorazepam. It's a benzodiazepine. It will sedate the patient. Okay, what next? Then we administer phenytoin, right? Okay, this is a part of the discussion and some extra things I have told you in this before approaching this question. Let me tell you one more thing. When for suppose you are for suppose a patient is comes to you, and the patient has undergone the seizures when no one was there, when not even his friend, not even his family member, no one was there, and he has gone through the seizures alone, in an alone setting. No one was there to witness. We have no witness because of course in when the patient is undergoing seizures or syncope, so we don't have any witness there, right? Now, how will you recognize that the patient has undergone seizure? So for now let me give you a scenario. The patient has undergone the seizures uh, in an alone setting. No one was there. The patient is not delivered to you in the emergency department, right? I'm talking about a different scenario. I'm not talking about this thing. I'm not talking about this question. Okay, so I was saying that the patient undergone seizures and now he's delivered to you in the emergency department. Now you don't know that even that if the patient has undergone the seizures, right, or if the patient has undergone the syncope, because people have found him on the floor. Now you and the eyewitness and the patient, no one knows that he has undergone seizures or not. How will you diagnose and how will you make your diagnosis of seizures? You will look for his tongue finding, because in seizures patient bite their tongue, mostly. This is a very specific finding and a very less sensitive finding, because this is not always present in the serious patient. But if it is present, then you will think that okay, man, this is the seizures, that's it. Another important thing, that when the patients have undergone seizures, they also lose their bladder control, and they also suffers urinary, they also experiences urinary incontinence. So the eyewitness might report that we have seen some urine around the patient. Another important thing you might witness, that after undergoing seizures, after a seizure episode, patient also have some confusion. We regard this as post-ictal state. Almost always in seizures, in all seizures and all type of seizures, we have post-ictal state, except for absent seizures. Absent seizures are seizures that usually occur in the child, in some adolescents, and not adolescents, some it actually happens in very growing minds. Anyways, so yeah, so as a patient who has undergone seizures, almost always have some confusion. If the patient is not having confusion, if you are not seeing tongue biting, if you have not seen the urine around the patient, then you will not think of seizures. You will think of some syncopal episode, some syncope, right? So this is a very important thing that I've told you, and you have to remember this for the rest of your life. Now we will just move towards the answer, and that's it. So let me tell you one more thing, and simplify this question. So first of all, step one, I have made the diagnosis here. I have made the diagnosis that the patient has undergone the status epilepticus, because you can see that uh, it is written over here that the patient experiences multiple generalized tonic-clonic seizures in succession without regaining consciousness between the episodes. So it is status epilepticus, right? I have made my diagnosis first of all. Now I will think about the management, that we will give first of all IV lorazepam. A benzodiazepine is given first to acutely stop the seizures, right? It's not given chronically. It's not given for management of I would say that for maintenance of seizures. Lorazepam is not given for maintenance of seizures. It is given only for acute setting. For acute setting. Again, it is given only in acute setting. Benzodiazepines for acute setting. Nothing more, nothing less than that. So they block. The benzos work fast by blocking the GABA receptor, right? And this increase the calcium influx and neuronal inhibition, right? So, but benzos have a short half life. That's why we need the longer acting agent to prevent the recurrence, right? So uh, now, the second drug for the maintenance of seizures is a phosphophenolatoin or phenytoin, and that's a classic anti-seizures med you will almost always encounter on a step one exam, right? So the next step to reach the correct answer is that phenytoin, you should know that phenytoin or phosphophenytoin, they are a voltage gated sodium channel blockers in the cortical neurons, and they slow high frequency neuronal firing. So that's match with our which of the following is correct after B? Yeah, B is the correct one. Decrease sodium current in the cortical neurons. That's it. Again, let me tell you that yeah, I've told you that blocks sodium currents, and again it stabilizes the patient. So that's it for this video. I hope you guys liked it. You guys should like our video, comment if you have any question, share the video with your friends, family. If your family is interested in USMLE 7, and if your family is doctor too, share with them as well. And tell them that we are doing really good work. Thank you so much, guys. See you in the next. Take care.